Good morning, everybody, and welcome to Real Life Orthokeratology. My name is Dr. Stephanie Wu, and I am the founder of Wu University and the host for today. And this event was so exciting for me to organize. Our last myopia management symposium had over 700 doctors on earlier this year, and there was such a huge request for orthokeratology specifically, which is why we created this event. It's now my pleasure to introduce Dr. Nick Despotidis. Dr. Despotidis practices in Hamilton, New Jersey with Barry Tannen, Ivan Lee, and Noah Tannen. Together, they have one of the largest practices in the country specializing in myopia management. Something else really amazing about Dr. D is that he has written 2 books. I think he's actually written more than that, but he's got 2 incredible books that I have personally read myself. My Children Are Nearsighted Too, and A Parent's Guide to Raising Healthy Children with Healthy Vision. He also has a phenomenal workshop. It's called Supercharge Your Practice. It's at Vision by Design, and I have personally had the pleasure of hearing from Dr. Despotidis, and we are so lucky to have him today. He has a TED Talk. I highly encourage you to watch that as well. And he is on a mission to help with myopia management and orthokeratology specifically, and is just one of the most wonderful speakers that I have ever heard from. I'm so excited and honored to have Dr. Despotidis with us today. So thank you so much for being here.
Stephanie, thanks so much for inviting me. So today, I have no financial disclosures, and I'm very proud of that. I'm a private practitioner, and I speak to you from a private practice, just like most of us who are listening in today. The main thrust of the talk today is really, why would you integrate a specialty like myopia management into your practice? You know, the speakers today will talk to you about how, and I will touch on that quite a bit. But if you don't know why, I really think your efforts will wane. The why, like they say, is the most important aspect. And I think that's why we have flourished in our office. So a little bit about our office. We opened up about 33 years ago, and we started what's today referred to as myopia management in 1992. So we've been doing this a long time. We have 1 location with 6 optometrists, all full-time. 4 of us are partners, and we have 2 residents in vision therapy and practice management. And I think one of the important points I'm going to try to drive home today is that each of the partners work 3 days per week. And the reason that's important, if you're going to implement a lot of the suggestions I make today, you can't be seeing patients 6 days a week or even 5 days a week. You really need to make time to work on yourself and to work on your practice. So this is our practice in a flow chart. We have 3 divisions within a large multidisciplinary practice. Barry and I started the practice again 30 years ago, and Ivan to the left, Ivan Lee, joined us about 20 years ago. Barry takes care of the vision therapy division. He is in charge of that aspect of the practice. My aspect is myopia management, and Ivan takes care of primary care. Primary care includes medical optometry, eyeglasses, things that you would normally see in traditional optometry offices. So we basically have 3 practices within one. Dr. Noah on the bottom left is becoming a full partner within the next 4 years. He doesn't run the division, but he's in all 3 divisions, an extremely vital part of our practice, as is the residents. Ashley and Alina, they do primarily vision therapy and also primary care and medical optometry. So together, the practice doesn't work unless all 6 of us are working in this totality, but we have divisions within the practice. So I have 3 main goals. I really would like to teach you how I acquired quality patients. And a quality patient is one who's seeking my type of care. I'm also going to touch upon fee determination because that's what most practitioners want to discuss. How much do I charge? And I'll tell you why that's an anemic question. And the third question is how staff management. If there's one question I get more than ever right now is where do I get staff? Because during this pandemic, it's been a challenge for every business. So let's start about all the journals that are putting out articles on aesthetic optometry is a term I'm starting to hear, nutraceuticals, genetic testing, of course, the dry eye center of excellence, scleral lenses, the neural lens, medical and coding and billing optimization, and of course, myopia management. And I often wonder to myself, if I was a general practitioner that tried to be good at everything, I'd be losing my mind at this point, because somehow when I read these articles on all these different, I don't know if they're subspecialties, but they're certainly modalities that we are encouraged to offer within our practice. If I left one out, I would feel like I'm losing something, an opportunity. So why do we feel as a profession, just because we can do these subspecialty or these modalities, why do we have to do them? And my kids refer to the term FOMO. I think that's become familiar now, fear of missing out. I like to look at it as the joy of missing out. This is a term I picked up online. I get tremendous joy out of specializing in one topic. I become extraordinarily well in one area. So I'm not stressed and I don't feel like I'm missing out on anything when I get all the noise. I almost consider it as noise. I'll read it of interest, but I don't feel I'm missing out on anything. So I think one of the reasons practitioners feel they need to include all these modalities within their practice is they're afraid maybe that they're missing out on a golden opportunity to supplement their practice. The other reason is I really do feel the traditional staples of optometry, at least in eye care, are fading. The eye exam is becoming more of a commodity, if you will. Insurances seem to be capitating what we can charge. Eyeglasses, when I started out 30 years ago, our prescription flight might be 5%. We knew there was a problem in the mid 90s when it was increasing to 12%, and now it's much higher than that. And of course, with soft contact lenses and their ability to get them online. So we have a partners meeting once a month, and we include all the partners, all 4 partners. And Lisa, who's in the lower right, has been in our office for over 30 years, almost from the beginning. Joined us 1 year after we opened, and she is our business manager. And we review all these subdivisions: primary care, vision therapy, and myopia management. And we compare the revenue generated from each profit center or each division from today to the same period in 2019. Like all of you, we've scratched 2020. And the only profit center that was stagnant, was stale, was primary care. So I turned to Ivan, who, as you recall, Dr. Lee, he's in charge of the primary care. And I said, what's going on? And he goes, it's medical. So then I turned to Lisa and I said, what's going on with medical? Are we scheduling less medical patients because of the pandemic? In our office, we have limited scheduling because of the pandemic. And she goes, well, to be honest with you, Dr. D, that's one factor. But the main factor is that, items that we do a lot of, punctal plugs, have become an inclusive code, as opposed to years ago, we used to bill for each puncture, lower, upper, left, right. Extended ophthalmoscopy and photographs we used to do on the same visit. Now we're not allowed to do that. I turned to Dr. Lee. I said, is that true? He says, yeah. And I said, Lisa, has the amount of reimbursements that the doctors get from insurance plan increased this year? And she starts laughing at me, like in that lower right picture. She goes, boss, they haven't gone up in years. But the reason I asked is, like you, I'm paying more, it seems, for everything. So I think another reason practitioners may feel compelled to try or dabble in all these modalities is that their revenue is decreased from factors like accepting more and more insurance plans. So you need reasons to integrate myopia management into your practice. You just can't say, I'm not going to do it. The one thing I want to say is that you need good reasons. You need extremely strong reasons to integrate. You can't dabble in myopia management. The reason I decided to focus on it 30 years ago or 25 years ago, and very seriously when it became FDA approved in 2002, was these 5 reasons. I wanted to improve my practice revenue. That's pretty obvious. At that time, I knew that my dependency on insurance plans was growing. People liked us. They were referring friends from the office because we were in their plan. And I knew this was a problem. So one of the goals when we instituted this in 2002, for example, once it got FDA approved, the CRT lens, is to reduce our dependency on insurance plans. I really wanted to improve the quality of my life in 2 areas. And we often don't realize this, both in and out of the office, because we were busy, but we weren't necessarily profitable. In other words, I was working quite a bit, at least 5 days a week, at that point, probably 6 days a week, and seeing about 4 exams an hour. Yet we were still falling short sometimes at the end of the payroll cycle. I also wasn't feeling professionally fulfilled when we were very, very busy. So the reason I brought myopia management is I wanted to feel better. I wanted to feel like I did when I graduated optometry school. And I really wanted to be unique. I wanted to stand out. I wanted to help my patients, specifically my pediatric patients, in a unique way that my colleagues weren't at the time. So these were my 5 reasons, and they're pretty weighted equally. I would say the one where I was going into the office and not feeling fulfilled was probably the primary reason I integrated myopia management. So I want to start by talking about how I attract quality referrals to my office. Now, what is a quality referral? A quality referral is a patient who comes in seeking myopia management, but already has been educated on why my office may differ from other offices in my vicinity from other offices. Like, why is my office different? This takes orchestration. This takes time and patience, but it works. What I used to do is try to educate parents in the exam chair, and that works, but it's an arduous topic. So how do you wow your patients into referring? Number one is before the consult, during the consult, during the application and removal class, and each follow-up. So in other words, these 4 times is when I wow the patient enough so they tell their friends and family, you need to go to Dr. D. He does this thing with this contact lens that my daughter sleeps with. He is amazing. His office is amazing. And you need to do this. So that's a quality referral. And it's quite simple how you do it, but it's not easy. You need to devote yourself to this. So step 1, during the pandemic, like all of you, I was extremely nervous about the solvency of my practice. I didn't know what this meant, like all of us. Everybody's focusing on PPP loans and PPE, protective equipment for the staff and themselves. We're closed several weeks, and everybody was talking about doing online consultations with patients now because of the pandemic. And I knew that was a dropping knife. I didn't want to get involved with it. But what I did do is contact every myopia management patient with my partners, not my staff, the doctors. And we hit on something that was really big, that in order for me to pre-frame my consult, I should pick up the phone or do a virtual call with them before they come in. Now, remember, they're a quality referral. Someone has said you need to go see Dr. D for whatever reason, in this case, and it could be Dr. Lee, Dr. Noah. Now, before they come in, I set up a virtual conference with them. It's about 20 minutes. During that time, I get a detailed history about the child. When did they start wearing glasses? Do they wear glasses? What is the parent's prescription? What is the child's online habits, which we're going to talk a lot about? And I also get the sense if the child is very nervous and sensitive. Remember, one of the things I always teach, just because a parent is interested in orthokeratology as a way to correct their child's myopia, doesn't mean the child is equally motivated. So I get a good sense by talking to the parent, and sometimes the child's included. But I'm going to tell you now, when they hang up that phone or disconnect that virtual call, they're going to say to themselves, I picked the right office. Now I know why my friend referred me to this office, because I can't even get a pediatrician on the phone when my child has an earache. And here this office is proactively reaching out to me and spending 20 minutes of undivided attention with me. That's the office for me. And I have to tell you, that was a tipping point that has increased our office over 30% this year in myopia management. So once they come to the office, we have the PPE, we have the PPE rather, we have the gloves, we have the door is still locked in our office. Nobody's in our reception area, but now have a good history. And I also have a motivational snack or prize for this patient. So you could imagine already we've differentiated ourselves from our colleagues. And this consultation takes upwards of 2 hours. So when I first started out, I would be trying to do this in the exam room. You know, there's a contact lens, you sleep with it, and you wake up the next day and you don't wear glasses. And the parent looked at me like I had two heads, and the child looked petrified. And they often didn't even get glasses or contacts at the end. So I lost on many fronts. So right now, and other panelists will go through what testing they may do and how they do it. But basically, we go through preliminary testing, then we evaluate the fit on the patient, we put fitting lenses. And number 3 is we make a confident doctor recommendation. I was taught to me a long time ago, I don't give choices. I don't say you could do this, that, or the other thing. You could do soft dual focus, you could do atropine, you could do, I just do a strong recommendation. That's what I found patients came to me for, is what do I feel is best for their children and why? And then I leave plenty of time. I learned this from my associate, Dr. Noah, plenty of time for questions, because any parent who is interested in orthokeratology as a form of myopia correction has a lot of questions. Take my word for it. And then they get enrolled in our program. And one of the clinical pearls I can give you is we schedule most of their appointments at the time of enrollment. So why do we do that? Because in the past, way 20 years ago, when the patient enrolled in the program and we wanted to see them, for example, the day after their application and removal class, is we'd have to squeeze them in. And then you don't leave plenty of time for questions. There's no wow at all. So now you could see already, you could see how we're trying to wow our patients. They didn't even enroll in our program, and we spent a minimum of 80 minutes with them, 20 minutes for the virtual consult, if you will, or conference, another 6120. This differentiates us from 99.9% of every healthcare provider around. But that's only the beginning. Whether they enroll in our program or not, and our success rate, our enrollment rate, has gone over 90% by implementing those first steps. So if you do nothing else other than just, take a few of my suggestions, devoting the time, making the commitment, will realize tremendous gains in any specialty you do, because we do this in vision therapy also. It's not myopia management, it's good patient care. So after the consult, a lot of practitioners are like, whew, they signed up, I did it. You did nothing. All you did is start the process. After the consult, we have a detailed report that outlines the results of the consultation and our strong recommendation. We have a follow-up email, again, whether they signed up or not, elaborating on the items that were discussed on the question and answer during the consultation. And these are the top 5 topics. What is the safety of orthokeratology? You know, you talked about visual hygiene, going outside more. Why does that help them? So I'll get some papers and I'll email them on that. What are the side effects of excessive phone use? Dr. D, you talked a lot about my child being on the phone. I knew it wasn't good for them, but can you give me some data? Can you give me something to share with my child? And you also talked about sleep, that my child's not sleeping enough. They're going to sleep at midnight and getting up at 7 a.m. and taking naps. What evidence do you have of that? Or more importantly, what articles can I share with my child? And the newest question I'm getting is, what design, what contact lens, what ortho-K lens are you choosing? So these are questions that need to be answered if you want to wow your patients and in detail. So I used to try to do this at the time of service at a checkup. It's impossible, guys. Any of you out there listening to me that has done any type of specialty care knows that we have a limited amount of time of chair time when they're there. So I've learned the skill of communicating my patients when they're not in the office, where I can control the conversation. Same thing with my staff. I don't have time constraints. So we went through two particular times in this process, the virtual conference and the actual consultation. We then set up an INR, application and removal class, and we do 3 separate things before the class, because I call this application and removal process an inflection point. It's where parents get buyer's remorse because children often are intimidated by the entire process. So we have 3 areas that we do before that encompass this INR, if you will. Before the class, we have 3 strong points. We give homework. And I have an asterisk next to homework because notice I'm using terms that are similar to school. Parent conference, virtual parent conference. I give homework. You're going to come back for a class. These are all orchestrated terms that we use that have really emulated schoolwork, because a lot of the children who are enrolled in our orthokeratology program are extremely good students. They follow instructions very well. So what homework do? We teach them at the time of enrollment how to insert a lubricating drop in their eyes. And we have them practice several times a day, because that helps our success rate at the time of the insertion and removal class. We also email them prior to the class to confirm they're doing the homework. If they're not, I may even set up a virtual call with one of my technicians to go over it. We are very big on sending them videos on how to insert eye drops. And of course, we remind them in our office, they are going to get another gift if they successfully pass their class. So you can see that my office is like primed for success, number 1. And number 2 is that we always keep the patient in mind. They want to be successful, but we need to motivate them more than just the myopia progression their parents are concerned about. So during this application and removal class, we allot about 60 minutes. And before we instituted, for example, this Amazon gift, we get a pretty good pass rate, but it was arduous for the parent. And I get the phone calls the night of and the next day and the week of. Now these 6 points really help us succeed at a critical time in the program. So you have to acknowledge this is high stress. So we use a high-level staff member, someone who has been trained in this, not only teaching the child to deal with a very nervous, normally nervous type A parent. During this period, we have a child sign or initial consent forms, or not consent forms, compliance forms, that they're going to wash their hands. They're not going to use tap water. They're going to put their lenses in every night. I don't care if they're 7 years old. Sometimes the kids follow instructions more than the parents. We have parents sign consent forms and we answer any questions they have. And this is a clinical pearl number 5. Again, this became elaborated during the pandemic, as we have the parents wait in the reception room or in their car until the child is able to do it twice. Insert the lenses twice, take them out. The tech is confident they're going to pass their class. We have the parent come back in at that time. So because now we have control. And then we ask the parent to videotape the child's final attempt because they were doing that anyway. And number 2 is we said, listen, if Johnny forgets how to do it when you get home, just show him the video. So these 6 steps have helped us at a very critical time in our process. Again, just because they learned and they did it 3 times doesn't mean much of anything. So after the class, we email them before they start calling us, before the child has all sorts of frustrations, or call them if we have nervous patients and saying, hey, watch these videos. Just to review, this is what we discussed today. Maybe it's without a plunger. Maybe it's how to use a plunger on the bottom part of the lens as opposed to a central part. Just to review, but I'll tell you, that's a ruse. The reason we're emailing them is because the parent normally has more questions, and we want to answer them before they come in the next day or the next week. This is critical, and you have to answer them with urgency, because in this day and age, nobody responds to us. No one responds to us. It's just the day and age we live in. We have a golden opportunity to stand out by just responding to our patients, and it's just great care. And oftentimes, we call or email the patients incessantly until they say, you know what, everything is smooth. Because we found if we did not do this at the time of the visit, we'd be overwhelmed with questions and issues we need to address, the least of which is the fitting of the Ortho-K lens. So this is where I feel you can solidify wowing the patients and really differentiating your office from any other office. Now, remember, we're talking about myopia management now, specifically orthokeratology in kids, but you can apply this to any subspecialty you desire. What you cannot do is do it to every subspecialty. You can do anything, but you can't do everything. And I think once you understand that, you will become such a better practitioner, such a happier practitioner. At least that was the case for myself. So these follow-up visits are my opportunity to market, where some of practitioners do Google optimization or Google ads, or I don't know what else they're doing. I know when there's no better opportunity to explain to a parent and a child why I am the best practice for their child. So we do visual acuities with and without the lenses. We, of course, evaluate the fit. And I think that's where most practitioners stop, 1 and 2. I go beyond that. All the doctors go beyond that to say, okay, let me go through this compliance. Is the patient compliant? Are their lenses clean? Are they wearing them every night? If I change the lens, I discuss why I change the lens, because I have found parents often very nervous. So for example, if the child is seeing 20/20, sometimes the parent asks me, is that too good? If the patient's seeing 20/25, they'll say to me, well, why aren't they seeing 20/20? So I have found I need to make the time to explain to the parent in detail why I'm making a change. If you rush the parent, you have not wowed them. If you don't wow them, you're not going to get their referrals, and you're not going to get quality referrals. We always discuss screen time, because parents are desperate for help because they know their children are often tethered to their phone. We know as optometrists and eye professionals that this keeps them indoors, and it's much more likely for their eyes to continue to deteriorate. I discuss sleep because sometimes I find 4th graders going to sleep at midnight to get their homework done. It's ridiculous. And I always discuss the need not only for outdoor activities, for socialization. Children have been virtually learning now for almost over a year, right? They've lost the ability for eye contact. They lost the ability for emotion, for goodness sakes. Parents know that as health providers, we should care enough to spend a minute to talk about this. And that is a wow factor. That is a critical non-essential, which I'll talk about a little bit later. It's not critical to good ortho-K care, but I think it's critical to taking good care of your pediatric patients and also for having the patients refer to you. So any niche business really knows how to create raving fans. And what I described to you in a very short time is how we create raving fans, raving parents that say, listen, I don't know who your eye doctor is, but you have to go to this practice. They give snacks. They take care of my child well. They talk to my child respectfully. They always answer my questions. When parents come to our office, they know we're a different healthcare practitioner. In order for you to achieve a multi-figured specialty practice, you need to make time to spend with your patients. I just couldn't say that long enough. So let's talk about fee determination, because that's where a lot of the questions, I would say most of the questions lie from practitioners. But I'll tell you one thing. If you follow these exercises long after this lecture is over, I promise you, by calculating the cost involved with treating specialty care patients, not ortho-K patients, you'll establish a foundation that will resonate throughout all the services that you provide within your practice. In other words, when you understand the limiting factor within your practice and why you're charging the fees you are, you'll become a better business. You'll become a better practice, if you will. So I like to discuss chair costs. Consultants, which I am not, sometimes trash this, but to me, it makes so much sense as a private practitioner. Remember, today is Sunday. Tomorrow, just like most of you, I am going to be in the office on Monday saying better one or two and practicing exactly what I preach. This makes a lot of sense to me as a practitioner. A chair cost is the dollar figure a provider must produce per hour to support their overhead. And usually it's calculated by the chair cost is you take your gross revenue, you subtract your cost of goods sold, and you subtract your net. Sometimes that's just all of the doctor's salary or the owner's salary. Sometimes it's the owner's salary plus leftover. And you divide it by the total number of patient hours you see in a year. And you get a number. It could be $150. Sometimes it's low as $100 if you're a mom and pop practice and your spouse is the office manager and you're the doctor and maybe one other place and you don't have the latest equipment. Maybe your chair cost is about $100 and change. I doubt it these days. But I would say these are just sample chair costs. If you can't figure this out, you should ask your CPA. Astute business people just know it without asking. Remember Lisa, how we started this off? She doesn't know anything about chair costs, but she knows exactly how much it costs per hour for us to see a patient. And then when I started fitting contact lenses early on, or specialty care contact lenses, I thought because it was $1,000 or $2,000, I was making money. And she explained to me, the way you're caring for patients, Dr. D, you're losing money. So let's see how this is possible. This was a good article I stumbled upon. It's a Envision website, a newsletter, a blog, and the title is Why Chair Cost is Less Relevant in an Era of Managed Care. And I think this is a critical article for most of you to digest. Chair cost implies there is a problem, or the problem lies with fees charged, not with the way the doctor is managing overhead, overstaffing. Now, I'm sure a lot of you are giggling now. Very few of us out there are overstaffed right now. So a lot of times we blame things like staffing when we are the problem, as I'm about to show you. Number two, in the real world, some no-charge follow-up visits take longer than a complete exam for ODs, for which ODs receive a fee. In other words, a check can take much longer than a comprehensive eye exam. So we could do this for any subspecialty, specialty contact lenses, orthokeratology. It's true. My follow-up visits sometimes take longer than my 20-minute exam. And number three is, and I think this is the critical point here, doctors often find themselves in a situation where they can't pass on the increased operating costs in the form of higher prices to their patients because of managed care. So you remember when I spoke to Lisa and I said, have our fees gone up? She giggled. And that's absolutely the case. If you're going to really grow a specialty care practice, you're going to have to make a commitment. And it can't just be, well, I'm going to do dry eye because some of the procedures are not covered by insurance, or I'm going to do this type of lens because it's not. It's because you're in the middle. You haven't made a commitment. One of the things you remember that I brought myopia management to my office, I made a commitment to drop all my eyeglass plans and drop almost all, 99.9% of medical plans. It took a long time to do that, but I did it. Was it scary? Yeah, very scary. But the thing was, I could never have grown my practice to the level that it has, because as this author states, that I would be capitated. There's a limit to how much I could charge. And as eyeglass scripts walk out the door, and certainly contact lens scripts walk out the door, what the heck am I going to do? So I have to tell you that good incorporation of myopia management into your office, simultaneously, you need to make a commitment to become less dependent on managed care plans. I don't see any other way. That's not exhausting. And we'll talk about that at the very end. So this is a mock chair course. Now my chair course is probably 3 times this amount. Actually, it is almost. So if I'm spending 1 hour in a consultation and I do 6 follow-up visits over the year, they're 20 minutes each, I'm spending about 3 hours a day, not including the application removal class. If your chair cost is $200, I'm up to $600. My material cost, depending on what lens you fit, how often you change it, is $400. So in this particular scenario, it's $1,000 cost for you just to turn on the lights and pay for the materials. You have made no money whatsoever. So now you have to make a decision. If you charge $1,500, is $500 enough to go through this? If you charge $3,000, is $2,000 enough for you to do this? You can't look at your competition because you don't know how your competition is going to treat your patients. You also don't know how they're performing ortho-K. Like so many services we do, it depends on the ethics, on the skill of the practitioner providing it. So for you to say, they're not going to come to me because I am more expensive or less expensive than the practitioner across the street, doesn't apply to specialty care, at least in my experience, any specialty care. You have to give your patients a reason to come to you that's besides cost, because is irrelevant. I am telling you, I have charged from one gamut over the past 30 years to the highest gamut, and cost was never a factor. It always paralleled how much of a commitment I made to my patient, to making them feel that they were well cared for. And this is why most practitioners will never do myopia management, no matter how popular it becomes, whether it's soft lenses or atropine or ortho-K, is that there is an insidious chair cost to myopia management. The child and the parent are often very meticulous. And if it's not their vision they're focused upon, it's other things. And if you don't spend the time to address their questions, you'll never get the qualified referral. So what this is an Excel spreadsheet that I've gotten more than once from a patient who is taking their monocular VAs. This one's binocular, but I have monocular VAs. This patient is actually taking morning and evening. Oftentimes, initially, I used to think, where are they getting their charts? They're printing their eye charts. They're using their iPhones. Now, if I was a practitioner who is doing all the subspecialties that I described early on, at this point, I would cry uncle, no matter how good I am. But because I've done this a long time, and because I'm trying to really teach you real life integration, you have to be prepared for the parent and the child who's going to choose Ortho-K as a way to integrate or to correct their myopia. So oftentimes, people fail or give up on all the subspecialties. It doesn't matter if it's scleral lenses or dry eye or any of the ones I discussed because they thought they misinterpreted a high gross for high net. And if you do not charge appropriately as dictated by your chair cost, your gross will be high, but your net will be low. And I think this is a very important distinction. Here is this very popular show called Shark Tank. And I have a good friend who has built a multi-million-dollar physical fitness system. And before the pandemic, he was about to sell it for tens of millions of dollars before the pandemic. This is his favorite show, not my favorite show. Why? Because what I learned from it is I have a lifestyle business. What they are referring to at Shark Tank is a growth business. It puts all the emphasis on growth. Being an entrepreneur leaves little room for anything else in life. That's the philosophy of a growth business, where you're gearing up to sell your business. A lifestyle business is what I've realized I have. I've been practicing 35 years. You can hear it in my voice. I'm very passionate about what I do. I love it. And I hope to continue to do it for decades. It looks to profitability for personal income, keeping in mind growth goals. Growth is slower, but more incremental. I think most of us, we want growth right away. We're thinking of selling our practices before we've even developed our practices. Let me tell you something, practicing for so many years, optometry or eye care in general is still a great lifestyle business. I'm living proof, but you have to make the tough decisions. And that, in closure, I want to talk about staff because everybody right now is talking about staff. They don't have staff. Where do you get staff? So this crazy dentist, Patty Lund, about 20 years ago, my partner Barry brought his philosophy in where you have to build your business so it brings you joy. This was a new concept to me, to develop a practice where you're so happy inside the practice, it's just as happy outside the practice. It doesn't mean that every day of my life is Chuck E. Cheese or Disney World or Bed of Roses. Just like outside the office, my life is not always a bed of roses. Inside the office, it's not a bed of roses. But I have to tell you, I get almost identical gratification, different, both inside and outside the office. This is predicated on two things: cash flow, which we talked about, and also staff management. So how do you hire great staff? Well, let me tell you, number one, you hire them very slow, even in a pandemic. I don't care if you go months without hiring someone, you hire slow and you fire quickly. This is someone consultants have taught me through the years, and it's true. You need right now, tomorrow, to solidify your staff that you have now. You adjust their salaries where it should be. You give them growth opportunities. Do they want to do coding and billing, take a course for you, become a certified tech, become a vision therapist? And we meet with our staff 5 minutes every morning now that the pandemic is getting better. And that's just like having breakfast with your family. It kind of gets us ready for the day. You know, how many consults do we have this week? What's going in our office? Who's out? Who's not? It works really, really well. And we orchestrate happiness. I can give you over an hour course on how we orchestrate happiness. It doesn't happen by accident. Nobody works for salary in an optometric office. No one. Here in my area, McDonald's is starting at $15 an hour if you go to www.mchire.com. So we have Bagel Wednesdays and Lunch Fridays. I get gifts on Black Fridays for the gift. I always say goodnight to my staff, and I always say thank you. These little things are the strongest thing you could do to improve the quality of your life within your practice. So basically, these 5 steps is how we embed happiness in our office. We retain the best people. So tomorrow, you solidify their salaries, you meet with them, what career goals do they have? Do they want to go back to school? I was amazed When I did reviews this past June, I would say 50% of my staff showed interest in going back to school in some form or another. Blew me away. So we reimburse them for any course they want to take, even if it's not optometry related, because it keeps them aligned with our office. We hire the right people. We hire slow, and I'm going to briefly go over that. We give them support systems called help guides that I'm going to go over. We develop these people. Like I said, we keep on making them better, and we orchestrate happiness. So these 4 things will allow you to offer any specialty care that you decide. Hopefully, myopia management is your hiring process, help guides, what we call position agreements, and staff reviews. So Amazon in our area is hiring at $24.50 an hour starting salary. And everybody says, how do you compete with that? I don't. I'm not Amazon. They have systems to get people up in training in days. But you know what? Their turnover rate is over 150% a year. They're struggling too now, even though their system is predicated on turnover. Can you imagine running your business where their staff turnover is more than 100% a year? So don't compare yourself to outside. The nice thing about myopia management, guys, is everything that happens is dependent on me, not insurance plans, not on the economy, not the pandemic. I have total control on what goes on in my practice. So what we do is we use Indeed. Sometimes we literally go through dozens of applicants and then dozens of virtual interviews. We give them aptitude tests through Indeed before they come in. When we invite them for in-person interview, I would say only 1 out of 10. 1 out of 10 people who have responded, taken a test, have come in because already they know we're different. So you could imagine how frustrating it is for us as well as you when I'm down 2 staff members and we're looking for months and we're still not filling these roles. You could imagine how frustrated I am and my staff, but we hire slowly. We finally do an in-person interview. We have an invitation to come back and observe, and this is twofold. Do you like standing up like our pre-testers stand up? Do you like our office? And does my staff seem you'll be a good blend? And these last 3 points is I'm amazed how many of you leave them out, is the reference checks, background checks, and drug testing. We do this religiously. You know why? We've been burned so many times over. So help guides. So in the past, we would train people, but really not give them a driving manual, if you will, to reference. So this is a sample, just the introduction. We just got this Pentacam. Everybody's excited. And you know what happens? There's mistakes made. The topographies or tomographies are not very good. Patients get upset because their lids are being held open by Q-tips and things like that. So we document how the procedure is supposed to be done. And here's the key. We have our staff do it because ultimately the procedures will wane. And we said, hey, listen, do we have a help guide on how to do this Oculus Pentacam? And I think so, Dr. D. Let's pull it. Oh, we don't do it this way. Well, let's rewrite it. So it's self-corrective. It's not like I scream at people and say, you're not following the help guide. You devised the help guide. Are you following it? And then we put all these help guides in what's called a position agreement, because a lot of times we find someone, we give them so many things to do that they fail. So we put the manuals, the help guides, into what's called a position agreement. In this case, it's the myopia manager. So the myopia manager should not be answering the phone unless it's defined within her position. And lastly, guys, you got to review your staff. Even if you don't have the funds to give them a raise, they need this. They need this yearly, where you sit down with them and you tell them what's working, what's not working, and listen to them, and please thank them, just like you would any other family member, because they are giving us the best they can. That's why the average tenure in my office, even with the pandemic, is over 15 years, is because of these steps. And again, they're very simple, but they're not easy. So we are a crazy office, and we almost proud ourselves to being crazy, but we're professional. And I could tell you, if it wasn't for myopia management, then it wouldn't be, if it wasn't for myopia management, I wouldn't have this happy staff, because we were busy doing it. No funds at the end of the day for orchestrating happiness, and no time for fun. So when you do really dive into a specialty practice like myopia management, it really gives you time for fun. I want to close on this topic. This is a great book if you haven't gotten it, Atomic Habits. And he talks about when you make a decision to change a habit, or let's say you've made a decision now, you say, okay, this Nick, he sounds like he knows what he's talking about. I'm going to start doing this. What often happens is there's a valley of disappointment. You did your virtual calls, you got your chair course, you even got a procedure or two down there, and you met with your staff and you paid for lunch, and it's not working. And this is what actually happens. It dips. An example may be like treehouse eyes. Now, treehouse eyes, I think Dr. Mai at the end may be part of it. I have no financial interest in treehouse eyes other than knowing the co-founder. But I have to tell you, they opened up in the East Coast about 5 years ago. And I'm telling you, I'm sure this happened. I have no way of knowing it, but I'm sure it did happen because they had 1 or 2 locations. I didn't hear much from them. Now, all of a sudden, it seems to me they're growing throughout the country, right? I am sure it's because the business people behind it are familiar with this. They knew, listen, there is a learning process. There is a curve. So this way, they've refined their systems. They've stayed the track. They made their systems better, and then they get exponential growth. So what you think is going to happen when you decide to institute myopia management is a straight line. What is actually probably going to happen is you're going to be disappointed. But if you stick with it like I did and like so many others, I promise you can't help but go up. And this is also from the author. He quoted this, this journalist, Gail Sheehy. If we don't change, we don't grow. If we don't grow, we are not really living. Growth demands a temporary surrender of security. It may mean giving up of a familiar but limiting patterns, safe but unrewarding work, values no longer believed in, relationships that have lost their meaning. If you don't go in, if you're not all in and don't make the scary decisions, then your practice will not flourish, at least your specialty practice. That's been my experience. So I thank you very much. I often write at least 3 times a year for CL Spectrum, and you'll know the papers that I write often have my patients in them because I'm so proud of how happy they are during a very stressful time in our practice or our lives, doing something like putting a gas permeable lens in their eyes. Thank you so much.
Wow, Dr. D, that was absolutely wonderful and inspiring as usual.